Right, welcome to our public board in July, and it's going to be a warm day today, so I hope everyone's sitting comfortably. I just want to let everybody know as we start that we are recording this meeting today, and in fact it is also live transmitting to technically to members of the public, but actually, as I understand it from Richard, that we've got 4 governor colleagues who've asked to observe the board. So I'm hoping they can hear me. I just wanted to welcome them. And Richard, do you want to tell us who they are, just so we can also just recognise that they're participating?
Certainly, yes. So we're joined this morning by Paul Joy, Paul Kelly, Fiona Judge and Helen Clark.
Lovely. So welcome to our governors. And I know for some of you it will be your first meeting that you're observing. So I hope it's a fruitful occasion for you, and no doubt you'll give us some feedback afterwards. So without any further ado, I want to start the formalities of the meeting. Have we got any apologies that we need to note today? I think we wanted to know Chris Oakes is an apology, isn't he, for this morning's meeting, I believe. But I think his items are being covered by Fiona and David Ledger.
Yeah.
Are there any other apologies that we're
Not that I'm aware of, Krishni. No.
Okay, right.
Have we
Okay.
Julie Shepherd? No, we don't have Julie.
Julie Shepherd.
Julie's an apology, I think, as well.
Julie's an apology. Okay.
Thank you.
Okay, thank you very much. Okay. Any declarations of interest for items on the agenda? Okay, I'll take that as none. Do remember for colleagues that have access to the raise hands facility, that's probably the best way of signalling that you want to speak. Obviously, if you do want to use the chat facility, then please do, and I'll try and keep an eye on it, but I will quote from that. So it's important that colleagues recognise that what goes in the chat facility is also potentially going to be in the minutes as well. So moving on then to the minutes of the previous meeting. First of all, just to invite any points of accuracy, please. Can I take that as none? Okay, excellent. And any points of any matters arising that people would like to raise that are not covered in the minutes? Okay, I'll take that again as none. So I just want to then move on to the action sheet from May, and we do have an action sheet indicating which items are complete. The one action that I could see that was outstanding was we agreed at a previous meeting that a board workshop, which would include an item on social prescribing, would be arranged as part of the board development work plan. I just wondered whether executive colleagues have a view on whether that item, given the deferment around COVID and where we are in terms of the Health and Care Partnership, when would be a good time for that to come on to a board development workshop plan? Any advice from colleagues on that? Angela?
I think it's obviously something that is dependent upon the NHCP position, which I think is probably something, the next meeting of that will be September. So I think we probably need to take stock after that, Krishni, in terms of whether there is any further information before we plan. But before that, I think it would be difficult too. Yes.
So should we take stock at our September meeting then of where we are, and just, as you say, agree an appropriate time frame at that time? Okay. Thank you very much. And just in terms of the forward plan, which is paper C in our documents, I wanted to double check on a couple of items. So we had on our forward plan annual public meeting arrangements. Clearly, we were advised by NHSEI that plans for an annual public meeting should be put on pause, if you like. But I do think we will need to bring that, bring something forward around that. Fiona?
Apologies. Sorry, I think Angela might have had her hand up first before me, actually. So I just wonder if you might want to take Angela first. Just to let you know, Chair, that we've started to do a little bit of thinking about that, because obviously there are still a number of restrictions in place, and we've just been doing this week actually just a bit of an understanding of kind of what might be a framework for delivery, with a view to getting some colleagues both from the governor, council governor community, and also comms colleagues and any other interested parties, probably have a small task and finish group to work out actually what can we do within the circumstances, and it will probably actually help us think about some of our wider engagement work with, you know, using a virtual platform. So just to say that that is in hand, and we will be able to provide an update, but obviously in between meetings, I'm afraid.
Yeah, that's fine, Fiona. I mean, obviously, I think we have to acknowledge that the original advice was we shouldn't be planning for that. So we've obviously put all of those plans on pause. But I think the updated guidance suggested we can start thinking about it. So we just probably ought to record the fact that that's the reason why it is not on our agenda today. Sandra?
Yeah, sorry, Krishna. I just want to go back to the minutes. There is an open action around the patient safety framework. Kate may have some update, but where I am in discussions with Julie, we're still not able to take that forward. It's been delayed. It was delayed originally, but now it's continued to be delayed. I don't know, Kate, if we've got a date of when that will be coming, but it's, at the moment it still has to remain open.
It does, yeah. There was some communication that came out, I think, last week that says that the pilot of the framework has obviously been delayed, and then now looking at something linked to early 2021 in relation to the final framework coming forward. So, yeah.
Okay, thank you, Sandra. And just for clarity, everyone, it was minute FT 19158. It was the outstanding action relating to the NHS whistleblower support scheme, and we were awaiting the National Patient Safety Framework, which is what both Sandra and Kate were referring to. So we'll just note that we're still awaiting that Patient Safety Framework clarification, and therefore it remains outstanding. Thank you, Sandra, that's helpful. Just going back to the forward plan, the only other item that we will need to consider, and again I think we'll probably just need to take this away as an action. COVID may well be is a factor in this, but one of the things we've got to consider within the time frame of this year is the externally facilitated developmental review of leadership and governance. And that again was originally scheduled for July, but clearly is not something we're able to do. So Fiona, can we take that away as an action to consider if and when we will be able to do that?
So we've taken advice from NHSEI, and they've confirmed that while that the original guidance, the original reducing the burden guidance issued at the end of March still prevails, and we are not expected to be preparing for an externally well-led review at the moment. So they will advise us when that situation changes. But I do think that we are, we can be reassured that we've looked into that, and that is not something that we need to be considering at this meeting, and we will need to in fact wait for a signal from NHSEI.
Okay, thank you. That's helpful. Let's note that in the minutes and make sure that we might want to put a review date on that so that we don't carry it over to future meetings until we put it back in an appropriate schedule, Fiona.
Absolutely support that, yeah, and we've got it on our own internal schedule to chase it up in another couple of months' time. So,
okay, should we perhaps report back in November? Would that be helpful? Just at least, just as a verbal update to give us a sense of, are we in a position to take that forward? And it may be that the answer is no at that point, but at least we've asked ourselves the question.
That would be very happy to do that, Chair.
Okay, thank you very much. Okay, let's move on then. So I think that's all the major sort of the introductory items out of the way. So we're moving on now to our patient story, I believe is the next item we have. So I'm going to ask Jean Knight, our Chief Operating Officer, to introduce that for us.
Thank you, Chair. So I believe Hayley's on the call. So Hayley Charlesworth is joining us. Hi, Hayley, to share with us some of her experiences she's had with the 0 to 19 service. I mean, Hayley is an avid campaigner, disability rights advocate, and I'm sure will share with us some of the things that some suggestions and views she's had around the 0 to 19 service and how they could have supported her better with her son Harry, and any suggestions she may have in terms of how we can improve it going forward. So I'm going to hand it over to Hayley to explain to you all her story, and also share some of the great things that she's been doing with Harry's pals.
Good morning, everybody.
Morning, Hayley.
Thanks so much for inviting me today. It's brilliant to have this opportunity. So I'm here mainly to talk about the health visiting service and my experience. I have got 3 children, a 7-year-old, a 5-year-old and a 1-year-old. My 5-year-old Harry is severely disabled. That's because he had strokes prior to being born. And as a result of those strokes, he's got quadriplegic cerebral palsy. So Harry is very affected. There's quite a large spectrum for cerebral palsy, but for Harry it means that he is completely, he has no functional use of his arms and legs. He is about the age of a 3-month-old cognitively. He's got breathing problems. He's registered as blind. He's tube fed. Basically, he's probably the worst case of cerebral palsy. When Harry was born, we had a health visitor come and visit us. At that time, we was living in Coventry, but I think for today we want to be focusing on obviously with your remit, which is Northamptonshire. So we moved to Daventry, well near Daventry, village in Daventry, called Newnham, back in 2016. Harry was. No, was it 2016? Harry was 2 years old. The health visitor turned up and I was dreading it, to be honest, because I knew from previous experience in Coventry that it would just be a case of they had to do their routine checks, they had to visit children within a certain age range. So she turned up and it was quite a difficult experience, to be honest. Having a child with severe special needs is very emotionally tough anyway. There's not a lot of support for parents in terms of emotional support, or for Harry there's a lot of support. We had the occupational therapist coming to see us, physios, OTs, everybody. We had lots of different services for Harry, but in terms of parents, there wasn't really anything. So when the health visitors came, my first experience in Coventry, I was hoping to receive some sort of support in terms of what to do, whether there's any emotional support for us as parents, how we can access services for children with special needs, whether there's any groups that we can join. But we didn't have any information like that. The health visitor that came to see us in Daventry I think she was almost embarrassed because she didn't have anything that sort of related to our situation. She didn't have any information or advice, any literature. There was nothing. She literally came with her checklist, I suppose, of what they'd normally be hoping to see in terms of development. Obviously, none of that was relevant to Harry, so it's a bit soul destroying, to be honest, when you're in a very vulnerable time. The first few years of having a child with severe special needs, you're accessing a lot of services for the child. You're trying to find any services to help you as parents emotionally, and practical advice as well. So you expecting a health visitor to be able to provide you with some sort of support, or even and for the child as well. But there wasn't anything. It was it was the 2-year check. So, is your child using their hands? Are they gripping? Are they walking? Are they talking? Are they the right amount of words? How are they sleeping? Blah blah blah. But for me, all the normal rules, all of the normal developments are completely out the window. So it felt like a waste of time. It felt it was really upsetting, to be honest. I remember when the health visitor left, crying, because it just felt almost insulting that we were being asked questions that just weren't relevant, and it's just such a reminder of what you should So it was very difficult emotionally, and it just felt like a waste of time. So that's my experience of the health visiting service. And I haven't came on here today just to moan about that. I think with my work through Harry's Pals, it's to notice the errors over the past 5 years, notice what changes can be made, and turn those negatives into positives. So that's why I was very grateful to be able to speak to you today, because I think it's important moving forwards that health visitors are prepared to meet parents that are in a very vulnerable situation mentally, that really need that sort of any sort of advice, any sort of support for themselves. I don't think it's just about the child, but I do think if you're going in there concentrating on the child as well, that we need to remember that what is the current situation, how is the child disability presenting itself, what could we possibly do to help, what groups are there available. As part of Harry's Pals, which I set up, actually launched in January, we've been offering emotional support to parents. So I'm just going to run through, because some of it's probably not relevant to today, but it just gives you a little flavour of what we're about. And that's about providing respite breaks for parents. So we're providing breaks for parents in terms of weekend breaks or week breaks throughout the UK. So we're partnering up with hospices so that the child's already taken care of, so that the families of those children can get away for some much needed time out. It's very emotionally and draining. It's very emotionally draining, and also physically as well. So having that time out to spend with perhaps their other siblings that might not have had the attention that they wanted. When you've got a child with lots of needs, it's very difficult to give the time and attention to other members of the family too. So having respite breaks is really important, and not only to recuperate and spend time with the family, but also to give you something to look forward to. When you're in the thick of it, sometimes having that, knowing that you're having that week away or those few days away in a month's time can almost get you through. So I think respite breaks are more important than people realise. Also, like I touched upon, is the counselling and the I mentioned that we didn't really get any emotional support, and that wasn't through want of trying. We've and members of my family really tried hard to find any emotional support for us, and that's for having a child that you didn't realise that there was going to be anything the matter with brain injury. There was a lot of support for children that had Down syndrome or preterm babies, but for an unexpected outcome like we had, we didn't receive any emotional support, or there wasn't any groups that we could join. So the other part of Harry's Pals is about getting bespoke counselling and therapy to parents. So that's where I'm hoping to work with the help visiting team to provide literature to signpost families. So hopefully health visitors can go armed to families like mine and have something to offer. And that's going to be about Harry's Pals and about that we're offering this service for counselling. So that might be looking at counselling which is kind of coping mechanisms, which I found really useful. Having a child with severe special needs, and it's not just about special needs as well, it's also about children that have a severe illness. So unexpected outcome in the first few years is a roller coaster journey. You think you're getting on top of things, and then another diagnosis will come, or something else will happen. So having coping mechanisms is really important. So that was useful for me. But for some families, it might just be that they want to talk to somebody with sort of traditional counselling. And the final thing is campaigning. So obviously, like today, I'm trying to make a difference in terms of the health visiting team, so that families like mine are actually feeling supported by the health visiting team, and it's not just something they have to sort of grin and bear, which is almost how I felt. And yeah, it has a big impact when over and over again you're not receiving the support that you need. And also we're going to be doing setting up a buddy up system as well. It's very isolating, and I think I touched upon the fact that you feel like this is you're the only person this has happened to. So to have a health visiting team to come over and say, is your child doing this, this and this, it's hard, because you're always looking at the what should have been. So sorry, I rambled on for a while there, but I just want, if there's anything that you as a team can do to help support Harry's Pals to get the information out there to families, then we really are keen to try and make a difference to families like mine. Thank you.
Hayley, thank you so much. I know it can't be easy to come and talk to this sort of strange wall of faces that you might be able to see, but we really hard as it was to hear your story, and we obviously, it's a really important opportunity to understand your experience of our services and what we could do better in the future, and you've been, you've cited that as important to you, and I think it's really important to ask. Are you comfortable to take a couple of questions or comments from people? Would that be okay? So I don't know if any colleagues would like to ask anything or comment about what we can do differently in order to respond to some of the concerns that Hayley has rightly raised. So first of all, I believe we've got Rachel West. Rachel?
Hi, thank you, Chair. Thank you, Hayley, for your sharing of your story. I work alongside the children's services, and it really helps us to hear people's feedback. And I know that you've been working with the team and through the PEG to share your experiences too. So first of all, thanks, and thank you for the work that you're doing with Harry's Pals, because I think that's a really good additional contribution that the system then has for parents and families, which is brilliant. I guess the other thing for us is really to be able to continue to use your expertise around how we make that difference in those early days. So we've already started to do some joining up with the 0 to 19 and the specialist services that we have at NHFT to try to improve that experience around adjustment in those early weeks and months. But it'd be really useful to work alongside you, I think, if you'd be happy to do that with us, just to make sure that we are on the right track, and also to think about the wider system options and availability. You talked about Respite and the counselling support. So it'd be really helpful to share with you what we know is already out there and think about where the gaps are so that we can help influence what provision needs to be going forward.
Yeah, definitely. It'd be a great opportunity to, for me, obviously, what with what's happened with Harry, we can't change that, but I think almost feels like it, you know, it's if we can turn it into a positive. And yeah, I do believe I think there's work to be done, but yeah, I would love to get involved in any way I can.
Thank you.
Thank you, Rachel. That's really helpful to hear, because I think it's, as we've said, it's how we use, you know, the learning to change things and make a difference, and that's really positive to hear. Melanie.
Hi, Hayley.
Hi.
First of all, just thank you. You know, the demands on your time must be extraordinary, and to take a little bit more time to come and talk to us here today, we really appreciate your generosity. I wondered whether you could provide any kind of sense of how we could make it easier for you as a user of the service to provide this feedback, because listening to patient stories is incredibly important to us. As Rachel said, you know, getting that feedback to try and drive improvement. But do you think that there are ways that we could make it even easier for people such as yourself who want to make a difference, maybe thinking about how to campaign and set up organisations to help? Are there ways that we could enable that access to us more easily?
I suppose asking for feedback, maybe. I don't know, to be honest. I think it's about giving people the opportunity to come forward with their experience. So, or regular questionnaires, or sorry, I don't know the answer to that question, but I do know that if I would have been given the opportunity to provide feedback at the time, then I most certainly would. Sometimes it's really hard, especially when you're in the very early stages. Your capacity is quite low and you almost feel like, oh, it's just another problem to think about or something else to do. So I think if I was to have received something or had a phone call to say, how would you rate our service, that would have sort of jogged my memory to provide that feedback then.
Thank you very much.
Thanks, Hayley. So I think it's really helpful that we're getting the feedback, but sometimes you need to choose the right time to give it as well when you're ready, I guess, and that's maybe something about having opportunities that aren't just about, you know, both at the time the experience happens, but also something like this where you've got the chance to reflect on your experience and share things. Louise, and then Angela. I've got, oh, that's gone. Angela.
Thanks, Krishni. Thanks, Hayley. I know it takes a lot of courage to share a story, but we use a lot of stories in the trust, and I think your story just illustrates more about how we can use them and will use them. So thank you firstly for sharing. But I was particularly struck by your sense of the family, think family, and how we actually ensure that, you know, and I'm sure Rachel will be thinking about this as well as others, but that was the message for me, think family. And that was really important and resonated. And I think the other thing was around the lived experience and how valuable your experience is in shaping any emotional support that is provided or serviced, because whilst we attempt and genuinely attempt to get services right, it's the lived experience working with us that really will make the difference. So really thankful for what you've shared today, and those were the messages that really struck me. Thank you.
Thanks, Angela. Louise, sorry, I kind of moved on from you because I thought your hand had gone down, but I can still see it's up. So are you there?
Yes, I am. Sorry, I was on mute. I just realised I was. So I'm Hayley's 0 to 19 participation work, and we've been working quite closely. And I really want to say thank you, Hayley. It's really valuable that we listen to your experiences and we take them forward. So thank you for that. I'll check in with you after this meeting. What I am keen to do as participation worker is I am meeting lots of families within the 0 to 19 children's services who have got lived experiences and do want to share some really positive and some things where we can improve, the trust can improve. And I think it's highlighted that not everybody wants to make a complaint via PALS, but if we could take these experiences and use them, maybe come up with a protocol that we could, like Hayley's story, take it, she voiced these issues that she had when Harry was he 3, Hayley?
Yeah, or 4. So
3 or 4. So she raised these when her third child was born, and the same health visitor actually came out. And I just think what we need to do is, it wasn't a complaint, it was, was my experience, and I'm very keen on getting something in place where we can take the patient's stories somewhere and they get a response from the service lead that, you know, okay, let's look at how we can make recommendations so these experiences aren't passed on to another family.
Yeah, thank you, Luz. I think that's really important, because it is all about how, you know, it's not a great experience that Hayley had, but it's, if we can, I think Hayley, you've said yourself, if we can use it to make a difference, to change things and improve things, then at least that's a positive coming out of it. And I think, you know, that can be helpful for everybody. And it just struck me really that it, you know, just the general sense about the importance of person-centred care, really, that actually recognises that people's circumstances can be very different, and whilst we might have a process, a set of things that we normally do,
yeah,
those things don't always work for everybody, and we've just got to understand that, and sometimes it's I'm sure it can be hard to adapt, but there is something about how we help our staff as well, and people who work with our patients and service users, to adapt when those circumstances arise, because clearly your circumstances were very different, and that needed to be understood, I think.
I think it's just about looking at the like the family, and like, as you said, Angela, and their situation, and thinking, you know, are these questions relevant? If they're not, what can I offer them to support? And just making sure you go in there with a purpose. You know, for myself, it's not only you know, it's hard, you know, emotionally, but I think it's also tough for the health visitor to be turning up thinking, oh, I've not got anything to offer the family, and, you know, feeling like it's a little bit of a box ticking exercise. So I think it's about making the service sort of bespoke to, whilst, you know, maybe most of it is just one size fits all, I think it's being prepared for the fact that, you know, whilst my situation is, you know, severe, there's not that many children like Harry, there is still a lot of families with other disabilities, whether, you know, autism, and I think it's just being careful, because I think families are suffering a lot in those first early years. So yeah,
Thanks, Hayley. And I think Rachel made an important point about joining up with our, you know, where we've got other services that maybe have more specialist knowledge and skills and expertise. It's how we use that to support the kind of more universal services that we offer as well. So really important. I think we've got one further question or comment from Moira.
Yes, thank you, Krishni. Hayley, thanks so much for telling us your story, because I think you've had that lived experience, and only you can tell it. So it's really good to hear from you. The thing that struck me, and it's the point you made about the health visitor being better prepared and more able to adapt, and being, you know, needing to be sensitive to the family and what that particular child needs. And I just wondered, and maybe I can help in this way, to maybe put you in touch with health visitors in training at the university, because I think as they're forming their views and learning how to be a good health visitor, that would be a good time to talk to them.
That'd be brilliant. Yeah.
And if you'd like
Fantastic.
that, I can definitely, through Louise or Rachel, put you in touch.
Oh, definitely. That'd be fantastic. Thank you, Moira.
No problem.
Lovely. Well, that sounds like a really positive step that we can practically take just to really help people's development in from the early stages and understanding of the experiences that they might encounter. Because as you rightly said, Hayley, you know, sometimes a member of staff might feel very uncomfortable if they don't feel equipped to manage that situation as well as they might like to. Kate, would you like to come in?
Yes, it was just really to say that, like, to talk to Louise, you know, at a separate point to try and see what we can do in relation to the ideas you've raised around that patient feedback and how we can feed it in, but without using that formal complaints or PALs or whatever process, and what we can do about that and how we can make that more effective and you know, provide that feedback to our service users. And you know, yeah, thank you for raising it, but if we can catch up afterwards, I'd be happy to do that.
I'm happy if you know, you ever wanted to have another conversation, or we could have a different group and go through sort of the health visitors and maybe look at sort of actioning some of the points, and I'm happy to do that.
Oh, that would be fantastic. Thank you very much. Thank you.
Thank you, Kate. And finally, Louise, bring you back in.
Yeah, just want to say, I know sort of we have got the I Want Great Care, but that sometimes doesn't always fit. So I know Melanie's put in the chat that is really it is important because it isn't a complaint, and I think there's a middle line that maybe we could sort of come up with some sort of protocol. So I'm really excited about that, because that is one of my passions, that I want to get stories like Hayley's to the whatever clinical lead and fix things, and that makes the patient feel heard as well and valued. Thank you.
Thanks, Louise. I think it's a really good point about using stories about people's lived experiences more generally. I mean, we've done it here at the board, but actually, you know, making it a part of how we learn and how we improve, rather than, as others have commented, regarding these things as complaints necessarily. It's just, you know, it's important that we just recognise people's experiences, their stories, however people want to tell them, are just important ways for us to listen and learn, and hopefully make a difference. So Hayley, thank you so much. I think everybody's really valued the opportunity to hear from you, and I just want you to know there are a couple of comments you might not have seen, but David Williams, one of our other directors, has said hearing your feedback is very helpful. One key part of the work of NHFT is that we develop in partnership with others, and you know, more joint working could help us develop our services together. So I think some of the examples of follow-up and actions that we've talked about are about using that helpfully. So yes, and that really this is an extension of sort of co-production that we often talk about. So thank you so much. Really value the opportunity we've had to hear your experience, and I think there are a couple of follow-up points, not least I think you're already obviously in conversation with Louise, and Rachel's sort of made some observations as well, but I think some additional, I really welcome Moira's suggestion in particular about speaking to students, if you're happy to do that, because I think that sounds like a really positive opportunity.
Yeah, I'd be very happy to do that. Yeah, that'd be great.
Okay.
And if anybody wants to get in contact
much
with me separately, I'm sure Louise wouldn't mind passing on my email address. So great.
Lovely.
Thanks everybody.
Thanks very much, Hayley. Thank you. Okay, excellent. So really useful and really constructive experience of hearing I think Hayley's story, so thank you. I don't know exactly who was involved in setting that up, but really helpful one to listen to and learn from. Okay, so I'm going to move on then to our next item on the agenda, which is our organisational risk register. So I think in Fiona's, in Chris's absence, I think Fiona's going to pick this up. Fiona, if we can take, as with all papers today, the report is read, but you may want to highlight some key things that you want to draw to our attention.
Absolutely. So I just want to make sure I just unmuted myself. So we had a really good board development session in early June, where we talked about a new approach that we might take with our risks and some consolidation work that we probably needed to do to just take a sort of step back and have a look at our risks and really now look at them through the lens that the COVID-19 pandemic is going to be with us for some time, and so we really need to be looking at the risks and assessing the risks through that lens generally, rather than having a special kind of view on them on certain ones. And also over time we probably have got a number of risks that probably from a strategic level and from a board level could actually be aggregated, and actually some more of the detail could be managed at a different part of the organisation. So there was a lot of support for that from the board, and also trying to assess a risk appetite for each one so that we could actually use that to drive where we sought assurance and where we really needed to apply additional scrutiny. So the work is underway. The executive meetings have been scheduled in with the executive. The executive remains incredibly stretched and very busy and operationally focused on the day-to-day pandemic and the recovery work, but I'm pleased to say that we've got meetings scheduled in with pretty much all of the execs now to take this work forward. Our plan is to present something to the next combined executive board, so the second one in August rather than the first one. That will give us time to present an updated position to the committees at the end of August, and I'm hoping that therefore by September we will see a refreshed position, but just wanted to indicate that we hadn't there's quite a lot of work involved in this, and we just need to prioritise this in line with the other the focus that the executive has on other day-to-day matters. And I think I'll probably just close it there.
Yeah, thanks, Fiona. So I think it's really a development on from the discussions we've already had, as Fiona rightly said, in our board workshop about kind of next steps in relation to our risk management approach and refining that and improving that. So and I think it was clear at the time that that would be sort of subject to some capacity constraints, but obviously an important piece of work for us to take forward. So there are a couple of questions I can see. So first of all, Scott.
Yeah, thank you, Chair. Just following on from what Fiona's just said, excuse me, Maria, Richard and myself had a bit of a preparatory session ahead of the performance committee that took place at the end of June, following on from the board development activity that Fiona's spoken about, and then we expanded on that sort of dialogue as a natural consequence of how risk register was actually covered as part of performance committee at the end of June. So I just wanted to reiterate that that activity is still sort of live and happening, and that we're sort of living that values, not just as executives as Fiona's covered, but also as non-executives. I think probably what we were reflecting upon at the time was that some of the risks that we have, certainly if you apply a performance lens to the risk register, some of the risks that we have had in our risk register for a while have probably seen a reduction as a result of the current environment and the emergency measures that are in place. But clearly a number of those have had a different emphasis now, or sorry, I beg your pardon, a number of new ones have arrived related to the pandemic. So probably in a kind of bizarre environment, we may have actually taken a different perspective on the risk register this time around and actually rated it green, were it not for the fact that obviously we have a number of new risks coming in related to the pandemic. And it's just, you know, to recognise the hard work of the execs and their teams in managing the existing risks. The focus hasn't come off that alongside the new risks as well. So, you know, a work in progress, I think, Krishna, but, you know, at the same point in time, I think, you know, we need to recognise the changing flavour and environment. That's being reflected in the risk register management itself, and also in other activities like, for example, the performance dashboard and the workforce dashboard, because we've chosen to, you know, initiate some work amend the focus so that they're more appropriate given the current environment and the circumstances that we're all living through at the moment.
Yeah,
that was it.
Thank you, Scott. Thank you. That's helpful. Maria?
Hi, thanks, Krishni. I just wanted to say firstly that I thought this the report on the agenda today was really helpful, the way it was written and very clear. So thanks to Fiona and the exec team for that. I found the summary around the key changes that's been included. I know it's always been there, but I thought it was really helpful and really clear this time. And then just one question of detail in terms of the risk register. The top one in the table around charities and the financial position. I think we discussed that at the last board meeting, and I may have recalled it wrong. I thought that the risk around that was reducing, but I can't see that in the register. So I just wondered if something has happened since the last board meeting that's still a high risk for us.
I think David would like to come in. David?
Maria, thank you. No, it hasn't. The risk hasn't changed. The risk is lowering, and actually it's to do with timing and the conversations that we're having at exec board, which will follow through on the risk register, and then you'll see the reduction in the board meeting. So it's a timing of reviewing everything that's the issue here rather than any other problem.
But you are, so in effect, David, you are expecting that to reduce. That will just flow through if there's a lag in the reporting. Okay, thank you. Is that okay, Maria? Answers your question.
Yes.
I think probably just wanted to note really the comment in the report about reviewing what was a de-escalated EU exit risk, because clearly I think it's really helpful that the report highlights that as something that's going to increasingly be back on our agenda, albeit very much driven by national requirements, because the NHS response to that risk will be determined nationally. But I think, it is an area that governors have obviously been concerned about previously. So just worth noting, I think, helpfully, that the report does comment on that and notes that it will come back, reported back to September board once it's been reviewed. So Fiona.
Thanks, Christian. So I was just going to actually draw attention to that. So thank you for doing that on my behalf. And the thing, I just wanted to go back to something that we talked about at the beginning of the meeting, where we looked at the forward plan for the board. So we are the way in which we're going to be managing risk is slightly different to how we manage it currently in the risk policy. So what I thought I would do is because the audit committee is the committee that is responsible for overseeing the trust risk management arrangements, I thought I would provide an update report to the audit committee ahead of the board meeting in September, so that they can be clear on the plans that we're undertaking, and there's some internal changes that we're looking at in terms of actually how we manage risk. So I thought I would, in the meantime, if you like, I would sort of use the audit committee as my committee of choice to keep them completely updated with what the work, the sort of more detailed work that we're doing on the risk side of things.
Okay, that sounds sensible. Okay, if there are no further comments, I think we're just asked to receive the summary position. Clearly, we've had an update on the work that's planned and how that will be reported back to one of the board committees, the audit committee, and then the board. And we've also noted the point around the EU exit risk and the fact that the review of that will be reported back to September as well. So thank you, Fiona, that's really helpful. So that concludes our item on the organisational risk register. So I'm going to move on now to our strategy section. Now, if you recall, in normal times, there's ever such a thing as normal times. I'm not quite sure now what that will look like, but historically we've always had a strategic context report, but we agreed with the aim of reducing the burden on the executive that we would talk about any strategic context issues in a more with verbal updates. So we have the first item of this section is really just a public environmental analysis, which just allows us to, Angela and David in particular, to give us any verbal updates over and above anything in the Chief Exec's report. So is there anything either Angela or David would like to comment on? Angela?
Yes, thanks, Krishni. So just a couple of things, just to update the board that the unitaries continue to progress and will be recruiting to their chief executive positions next week. So that's ongoing. And the other thing that is happening as we speak is the launch of the People's Plan, the NHS People's Plan. So again, obviously that's not reflected in the chief exec report, but would want to cite the board on that. And then the final thing that I would just want to signal is that, again, the Children's Trust work in the county is progressing, and again they will be looking for a chief executive or are looking for a chief executive as well. Thank you.
Thanks, Angela. Yes, I think the People Plan landed this morning in inboxes, didn't it? So so important document for us to consider, and I'm sure some of the content we were sort of cited on because of the interim People Plan, but it's helpful to have the final document for us to address. David, nothing further to add from David, so we'll move on to my report, Chair's report to the board. I'm going to take the report as read, but I really just wanted to draw attention of colleagues to the decision by the Council of Governors to reappoint Melanie. So congratulations to Melanie on her reappointment. It is wasn't actually the term was not due to end until December, but one of the things that the Governor Non-Rem Committee agreed helpfully was that we would try and make these judgments as early as possible, so that if there was a need to recruit, for example, that actually we'd have plenty of time to do that. So we've agreed that, made that decision well in advance. And also just to note that the Council of Governors also agreed to extend Alistair's term to July next year to help us conclude the audit cycle, and also Moira's term to the similar period, really just in terms of helping us with the recruitment process, given some of the COVID challenges that we might have. So I wanted to draw the board's attention to that, and as I say, particularly congratulate Melanie on her reappointment. And I think just really also to reflect that we've actually had a number of board workshops in this period, and there were lots of comments from me about the various things that we talked about. And of course, some of those things have been very much reflecting on our governance arrangements and how they've worked, and what we might need to do differently as a result. So if anyone's got any further comments they want to make around that, by all means do. But I think that's not the end of the discussions we're having. Clearly, we're certainly going to continue those discussions as we go forward. But thought it was important to reflect some of those discussions in my report. Maria.
Hi, thanks, Krishni. Just a few things from your report. Firstly, just want to congratulate Melanie on her reappointment, and Moira and Alistair. That's really good news. And also just to recognise that I think in the past governors have been a bit concerned about us not being timely in terms of appointments to non-execs. So it's really good to see that systems are working and that we're ahead of the game there, and that those changes that some of the governors, and some I know who've moved on now, put in place around timetabling, that work is really paying off. So that's good to see. Also, just to recognise from the governor meetings we've had, how good it's been to hear the new governors who've joined us during a strange period where we're not able to meet together, but the way that they've been able to interact using the virtual platforms has been really good. And just wanted to congratulate the team on helping that to happen. And also the fact we've had such a good response in the elections. recognise the work that governors like Chris Davison and others did on the pre-election workshops that they held for interested parties. So that I'm assuming from the elections we've had and the response we've had that they helped us get really good governors who understand the role and are keen to be a part of the trust in place. So just wanted to recognise particularly Chris and the other governors who are part of doing that. And the final point, Krishni, was just to ask around the chairing of the Health and Care Partnership. I saw Paul White is moving on, and I just wanted to ask what the plans were in terms of recruitment to that role and sort of the interim until a new chair's in place.
Thank you, Maria. So just to answer that particular question, and I'll also invite Angela if she's got anything else to add, but what we because over the summer period, actually, we decided we were going to not hold a Health and Care Partnership meeting in August, and the next meeting will be in September. So it was really felt that actually and obviously we have support from NHSE and I to do this, that we would, in the short term, just manage with our local chairs of the different organisations, both CCG and provider chairs, supporting each other and working collectively to ensure the board is appropriately chaired and agendas agreed, etc. And the recruitment process has started and is now underway, and will go out to formal recruitment. I think the challenge will be historically, there have been some challenges getting agreement from other parties outside of the system, so the regulators, to appointments, and that has been challenging for us in terms of timing, but I think we have sought assurance that those processes will be sped up now. Angela, anything else to add to that?
No, I think it covers it. The process is underway, as you say, Christian. I think the only thing I would just add for people's assurance is that the NHCP board has continued to meet with that virtual, and that's worked quite well, similar to how you described, Maria, in terms of the governors. It has been, very useful to continue to connect and to be looking at some key priorities. So that has worked and will continue to work. As I say, our next meeting will be September, but process is underway, and hopefully, we remain hopeful that we will recruit an independent chair.
And probably also worth mentioning that there'll be other work happening in the meantime before September, looking at taking forward some of the actions we've actually already agreed over the last few months around particularly system governance and system architecture around that. And that's kicking off with a finance workshop on Monday, at which some of our colleagues around this table will be participating. So lots of activity. Just the formal board in August itself has been stepped down, but as Angela rightly points out, we've been continuing now for several months, and I think actually what I would say is a great sense of impetus around the work that the Qs have been doing, and take the opportunity to congratulate Jean and her colleagues around the system, because it has been really energising to hear about the progress that's been made in those discussions, and kind of a real sense of excitement that we're having these conversations about how we're going to work differently, and really picking up the momentum from the work we've already done on COVID together. And talking to other chairs around the country, I'm not sure that all systems have got that energy for post-COVID, so I'm quite excited by that. So just take a moment to recognise Jean and her other colleagues, chief operating officers, and I think people like Julie Curtis and Anna Earnshaw have been involved in social care as well. Okay, is that all right, Maria? Answers your question? Great, thank you. Yeah. I'm going to move on then to Angela's report. Angela, anything you want to add to your report over and above the earlier points you made?
Yes, I think, again, whilst it says it in the report about staff, I just want to take the opportunity to thank staff. We will continually do that because they are being absolutely amazing in not only managing a very difficult situation and continuously doing that, but I cannot underestimate the complexity of an incident whilst we're trying to restore, recover and support partnership working. So again, enormous thanks from me and the team to all of our staff. In relation to the report, again, I touch on the Veteran Aware Trusts, and people will know that we are holders of a silver award, but I can share today publicly, because it will go public, that we're now a gold award winner, which is fantastic. The Ministry of Defence have given us permission to share because it will go out today. So fantastic news, because that is a real recognition of the Trust's support and advocacy for veterans and their families, and it does involve us giving extra days leave for reservists, and it means our policies and procedures are supportive of this. So a real achievement and recognition. I'd like to, in particular, thank Alex from the HR team who leads this work on our behalf and has been instrumental in that. So that's really good news, I think. In relation to CQC, I know Kate will come on to talk about the CQC, but just to give assurance that we continue to meet with the CQC virtually. So the relationship meetings are continuous, Kate, Julie and myself in particular. And I know Kate will touch on the accreditation of the BAF and the support from the CQC, but I want to take the opportunity to thank our infection and prevention control teams in particular. You know, they have been absolutely amazing. They continue to be. I know it's not just about them, it's about all of our staff supporting the guidance, but you cannot underestimate the amount of guidance they've dealt with. It is absolutely huge. So I think enormous thanks from them for them that I want to share. Again, we talk a lot about, and rightly so, health inequalities in the board and our BAME colleagues in particular. Again, just to give assurance that we are completing risk assessments for those people that are disproportionately affected, and also those with protected characteristics. So again, good progress on that, and we continue to prioritise that. And then just finally, obviously important recognition in terms of being shortlisted for safety awards. Again, this is important. All awards are important because they validate what we're doing externally, but safety is a key focus, and obviously those awards in particular are important. And I think that in addition to the third nationally around the freedom to speak up in terms of the culture work is something that I'm hoping the board will see as good assurance around what we're doing and continue to do going forward. Thank you, Krishni.
Thanks, Angela. I don't know if there are any questions for Angela on her report. Okay, just a comment from me really, just to add that I'm aware now that Angela references the NHS Race and Health Observatory in her report, and Marie Gabriel, who's the former chair of the East London Foundation Trust. I think she's STP chair in North London as well. Yeah. She has been appointed the chair of that, and Marie is an extremely experienced NHS chair from a BAME background herself. So I did send her a congratulatory note because she was very supportive, certainly to us and to me when we were going through our own journey, and it was really good to see somebody with all of that experience on this agenda, and particularly on inequalities, actually being appointed as chair of that very that organisation. So I think that'll be a great connection for us as well to be able to use to support our own journey that we're going through. I also actually I meant to mention something that I was quite excited by. Angela mentions in her report, but actually the South Asian Heritage Month has been running. And there have been regular, I think, 4 events taking place every Monday. This is the first time, I think, we've collectively run the South Asian Heritage Month. So it's a new celebration. And I attended Mondays. So there's an event every Monday, and we're doing it with LPT. So that was fantastic as well. So joining that on Monday, And I mean, the only downside, I have to say, on a lighter note, is that there was cooking demonstrations without the opportunity to taste, because we're doing it all virtually. So that was a bit of a downside. I think if we're doing it again, we definitely need to be able to taste the food going forward. But it was lovely to see staff from LPT, staff from NHFT joining in and celebrating that together. And the event on Monday, which I know Angela attended, and Cathy Ellis, my counterpart chair in LPT, was also there. I think there were about 40 people on that event, so that was lovely, and a great celebration of culture and heritage, which I think are important opportunities for our staff to share. So I'll just comment on those couple of things just to add to Angela's report. So thank you very much, everybody. Thanks, Angela. We're now moving on to our quality section, the first report is actually our assurance report from the Quality and Governance Committee. Maura, anything that you want to draw to our attention?
Thank you, Chair. I'll just take the report as read. We've already had a segue into the ORR discussion that we had from Fiona, so I won't dwell on that. And also just to comment on what Angela has just said around our risk assessments. Obviously, that's a very live situation, and we're getting another update in August to Q&G. And one of the things we've asked for in August is a thematic analysis of any of the things that are coming through those risk assessments, because obviously if there are things we can learn from them, then that will obviously prove useful. And the only area I'd also dwell on is obviously the in-county safeguarding position, which remains very high risk for us as an organisation. And one of the discussions we had at the last Q&G was around the level of hidden harm that may be occurring and has been occurring during lockdown, and how that's affecting our population here in Northamptonshire, and clearly was of concern to Q&G when we last met. An area that we have highlighted is the need for really clear and formal lines of communication between the Strategic Safeguarding Board and the safeguarding leads in each of the health organisations. So I think that's one of the reasons why we're still rating it as red, but also drawing it to the attention of the board.
Okay. Anything else to add?
Nothing
Maura?
else from the report unless there's any questions.
Okay, and I can see Angela wants to come in. Angela?
Yes, just to update. I think just to share with the board that I did meet with Ian Curry, the chair of the Children's Trust, yesterday, and obviously we talked about safeguarding and the role of the trust in that. But what was encouraging is he is setting up a stakeholder group to work with him as the Children's Trust emerges. So that will start in September. So I think there'll be opportunity, Maura, to really sort of start to get engaged around that agenda and really focus on children's services, which is very pleasing indeed.
Good to hear.
Okay. Any other comments or questions for Maura on her report? Okay, I would just note that we'll have a further discussion on safeguarding at our private board later, and there's a further paper on that. Okay, thank you very much, Maura. So we then have the next item, which is Cqc Inspection. So over to Kate.
Thank you. Sorry, I couldn't unmute myself quick enough. So in terms of the paper, there was just a couple of little bits I'd like to highlight, linked to Angela's point earlier in relation to the BAF framework. We've obviously had assurance from the CQC that they're confident our board are cited on the infection prevention control practice, and that we are managing the risks effectively within the organisation, which is great news. We've had 3 emergency support framework meetings with our prisons and secured services since the last board, all of which have gone very well, and there have been no issues identified. And these particular meetings are very much focused on safety, so that's infection prevention control and safety. So those were very positive. The ESF process for Little Hay has been deferred because they had such a positive HMIP CQC visit prior to that particular discussion taking place. So the CQC didn't feel they needed to have any further talks with Little Hay. And just finally to let you know that the Martins registration has now been completed, and that's now sitting with CQC waiting for them to do whatever they do to confirm and verify that.
Thank you, Kate. Kate, this is just a process question, really. I remember a number of discussions around the registration of the Martins, so I just wanted to confirm in my own mind, and this was some way back, I think, when the CQC were actually visiting us. So is that just confirming the change that we agreed to the Martins at the time, or is this a further change, if that makes sense?
So it's confirming the changes that we needed to make to both crisis homes, but it's also included having a registered manager in place, which is the little bit of the process that's taken longer. Due to the internal systems and getting DBS clearance and all of those sorts of things. So yeah.
Excellent. Thanks, Kate, for that clarification. That's helpful just to understand. Okay. I thought it was really helpful to receive the CQC IPC BAF. It's probably important just to recognise that although the CQC aren't currently inspecting, they are finding ways of trying to gain assurance and reporting on that. And having a written document that covers that, I thought was very helpful. And shows that these things can be done differently, which in itself might be quite interesting to see how the CQC itself reviews its own arrangements going forward and make sure that they are obviously proportionate to the need. Moira?
Sorry, it took a while to unmute. I just thought it was worthwhile, given what Kate has just reported on, to recognise the work of our staff in the secured services, because not only have they maintained the standards that we would require them to in terms of safety and infection prevention, but I think we need to recognise that's done in a context of quite heightened tensions within the prison population, and also, increased security operations that the prison service have required of them. So I think they've done their work admirably under really difficult circumstances. So that's worth recognising.
Thank you, Moira. I think that's a really important point. And am I right in thinking that you recently attended one of their clinical governance meetings?
Yes, I try to go regularly to those, and I think they're very effective meetings in terms of being able to have those managers sit together and share things and concerns they have. So it's a really free and frank discussion, and actually it's really insightful into the sort of things they're having to deal with on a day-to-day basis. But I was very assured that standards are being maintained. That was the key thing I took away from that meeting.
And I think that's a really positive assurance to bring to the board, isn't it? It's you've seen that taking place yourself and heard that at first hand, so I think that's really helpful. Thank you. I can see that there is a comment. So just Melanie agreeing really the importance of the board recognising the particularly difficult circumstances that Moira has highlighted for our secured services and how well they've done. And I think in fact, one of them achieved some sort of national recognition, as I remember, from Public Health for the way they handled a situation. So all very important. So thank you very much. And I think we should ask, can we ask Jean that you pass on that recognition, because I think that's would be really helpful. Excellent. Thank you very much. Moving on then to the next item, which is learning from deaths and learning disabilities mortality review. So this is the feedback from the steering group, isn't it, Kate?
It is, thank you, Chair. So obviously the report has identified the processes for capturing and reviewing our COVID deaths within the organisation, and we currently keep those separately so that we can review and ensure we're just looking at any trends or themes. It's not a national requirement we do that, we just felt that it was good practice to undertake that. At the time of the report, we had 277 date texts linked to COVID. 79 of those have unfortunately been deaths, and we've found a further 17 from different types of investigations. So for example, a GP calling in or a relative calling in to say that unfortunately a patient's been deceased. So that brings our total overall to 96. I think it's just important to note that obviously these are patients whereby there will be multi-agencies involved, and we've obviously just captured those as part of our information gathering procedures. In terms of deaths overall for Q1, we have seen a marked increase in death across the services. Some will be related obviously to COVID, some will be related to COVID not being quite identified correctly right at the beginning of the pandemic. But however, learning from deaths, we had a full discussion in relation to this, and we've commissioned a full investigation into what those deaths are. There's terms of reference that have been approved by the group and by Dr. Nair and Dr. Lakapa as the medical leads in this particular piece of work. And the investigator's been appointed to start this week. So I think also we have done an initial review of some of the data, and some of the deaths are perhaps where we wouldn't expect them to be. So they might be linked, for example, to the memory assessment clinic or to older people's mental health services. And again, these would be deaths whereby there would be multi-agency involvement in their care. Just in terms of leader, rapid review of deaths are being undertaken by the CCG where COVID is a feature. Where COVID isn't a feature, obviously the normal process of the leader reviews still applies. The system had suspended those meetings, but actually we are due to start them, I believe, tomorrow, so that they're back on the agenda across the system.
Thank you, Kate. Kate, just a question on that thematic review that you mentioned. What's the timescale for that reporting, and how will that sort of feed through, which governance process will that feed through? Will that come to patient safety, or will that come to Q&G?
I think it'll probably come to both through the governance system. So for me, obviously, there'll be some reporting back to learning from deaths, which will then feed up into the system, up to Quality and Governance Committee around any sort of themes or concerns we've found in relation to those deaths.
And what about timescales? Because I suppose that my reflection is that with COVID ongoing, if there's any learning, we want to try and secure that as early as possible. So, but appreciate we're doing that against a backdrop of continuing capacity constraints. So I just wondered about that.
So the terms of reference have been agreed for the investigation. The investigator is somebody that's worked on the bank, that's got extensive history in investigation, so that we're using somebody with the right skills. We are hoping for a fairly quick turnaround, potentially a month. However, it does depend on what's found as part of the investigation process, but we have specified that we would want to learn lessons very quickly from anything we're finding from this particular review.
Great, that's helpful, Kate. Thank you. Nikki.
Thanks. Hi, Kate. Just a quick question, really. Sort of very conscious that everyone's very busy and systems and processes are different at the moment. But I just wondered if you could just talk a bit to when we're learning from deaths and SIs, how are we making sure that any learnings are actually implemented at the kind of at coalface, really, and getting right down into the services so that everybody understands what's happened?
There's a few things that we're doing, but I think the Patient Safety Committee is also looking at a piece of work and a new model of learning for the patient safety team, which will have impact on the complaints team and other services involved in learning lessons, whereby we obviously have action plans and people have to submit evidence against the action plans related to any kind of investigation. But on top of that, it was more about reviewing and making sure their business as usual 6 to 9 to 12 months following the closure of the SI or the submission of the SI or the complaint or the death investigation. So there is a model being worked through whereby the teams are now starting to contact services 12 months afterwards to say, right, are we business as usual? What evidence have we got? What changes have we made? And what the impact is on the patients and the service users and the carers going forward. So it's in its infancy, but I know that the Patient Safety Committee, which Sandra chairs, is actually, you know, very much focused on that at this moment in time.
That's helpful. Thank you, Kate.
Thank you, Nikki. Maria?
Thanks. It was just a question whether this area of work is something we're able to pursue with LPT in terms of comparative and sharing learning. Just whether we're picking that up.
Yes, I think we will do as part of the investigation, and we have had initial discussions across the teams around levels of death, and we've obviously benchmarked ourselves nationally, which I think the paper sort of highlights in that there was an increase of death nationally at that the same points that we were seeing it. So we have started to do that piece of work, but absolutely we'll hone that back in and report that through learning from deaths and governance. Maria, thank you.
Moira? Oh, sorry, Jean, I think. So apologies, Jean. Jean first and then Moira.
Just wanted to add a bit further to Nikki's question, really, about the dissemination of lessons learned. So the clinical investigations team sit within operations, and they go to each of the DMTs every week, talking about what they're picking up through complaints and through SIs. And that is then disseminated down through the assistant directors down to the heads of service and service managers and picked up within team meetings. And we're also then getting information up from team meetings through the governance structure into DMT. So they're having quite a constructive conversation every week around that. And that's examined further than in clinical exec, which then feeds back into Kate's governance process. So it is going all the way down and all the way up again.
Thank you, Jean. Moira?
I was just going to pick up on the LPT point that Maria made, and at the last steering group meeting, I think we recognised there was some merit in working much more closely with LPT on this whole agenda. So we had some discussions around the structured judgment reviews and the M&M process, because a lot of the stuff that's come out from the National Quality Board is, you know, primarily in the first instance very much designed around acute trusts. And I think as community and mental health trusts, we've got a lot to learn from each other in operationalising some of the national guidance. So that's something we've put forward as a way to work with LPT.
Thanks, Moira. David?
Thank you. And just to reaffirm, I mean, one of the advantages we've got is with my role reaching into LPT and having the connection there with transforming care. We've been picking quite a bit of this up. And Rackham picking this up for the system in Northamptonshire. So our director of mental health is really bringing everything together. And then what we've also been able to do is take into the East Midlands Alliance an East Midlands discussion around learning disabilities, transforming care, and what we're going to do to improve it. And that's happening next week. I can't quite remember if it's something like the 4th or 7th of August. But again, sort of if we think about the scale and building this stuff up, we're doing stuff in Northamptonshire, with Northamptonshire and Leicestershire, Leicester City and Rutland and the East Midlands. So I think we can get a really good learning of everything at scale and then apply it back to improving our services.
Thanks, David. That's really helpful. Kate, just one point of clarity, and this is sort of really more a point of detail, but I may have raised this before, and I'm sure I may have been given a reason by Julie in the past, but the ethnicity table on page 63, I think, I'm not quite sure whether I've got the right page number there, but it's not a traditional ethnicity table in that it's recording British and non-British, which isn't really the breakdown that one would now anticipate, I think, in terms of this kind of data. I'm sure there are limitations in the processes around how we do it, but I just wondered whether there's a plan to improve that, because it feels like a really important area for us to understand more about ethnicity in death, given everything we've learned from COVID.
No, I agree. And what we'll do is I'll review that again between now and the next board and see how we can improve and develop that, Krishni. So we get.
It may not be a quick action, but I think it's something we need to address. And just in terms of what we collect and how we collect and what we report, because I think that is going to be increasingly important for us to understand if we're going to address the inequalities issues that we know have been highlighted through COVID. So I'd be sorry, Kate, go ahead.
Sorry, Krishna, I do apologise. Yes, I will we'll review and then we'll feedback at the next board. I think it's right to be raised now, and it's also linked to one of our equality objectives around improving how we add data and information to our patient records as well. So it's sort of I think it's a linked piece of work, but I can come back with some feedback at next board if that's acceptable.
Yeah, that's absolutely fine. Just and not obviously expecting you to resolve it, just as an update on what we think might be possible and how we might take that forward. Thank you, Kate. Okay, and David just commented, we have raised this with the CCG, who have agreed that this will be a focus going forward. So helpful, thank you, David. Right, thank you very much, and thank you for everyone's comments and questions on that. Thank you, Kate. Moving on, but staying with Kate, we now have two further reports: serious incident report, and then the monitoring workforce safeguards. So, Kate, back to you.
Thank you very much, Chair. So in terms of the serious incident report, we have seen during the COVID period an increase of pressure ulcers, both on admission and new pressure ulcers sort of reported. And these have been service users that are either new to our services, living at home, or indeed in the care home types of environments. We haven't, though, seen any real increase in NHT lapses of care in relation to those pressure ulcers during this period of time. We do have one, though, that has gone into a concise investigation in terms of just for us to review any lessons to be learnt to be fed back into the system. I think the other bit within the report I just wanted to highlight was we have reviewed the falls data recently, and over the past 2 to 3 years we've had such an increase of falls, Datexes being put on the system, most of which are no harm or low harm, or perhaps more recently we've had people datexing service users that have rolled out of bed onto a mat onto the floor where we've had a low level full bed. So people are getting really smart and are being very successful in recording any kind of falls or incidences in relation to the patients. And because of the increase of datexing, we've had to just review our boundaries in relation to our SPC charts, which you can see within the paper today. And that's been done really to just reflect our better reporting culture, because it has moved on significantly in that period of time. We have had a small number of teams which have had an increase of falls reporting again during the COVID period of time. That has been directly linked to patient acuity and how unwell people have been whilst they've been sort of in our hospital settings during Q1. And also just to say that we are still reviewing all of the datexes related to PPE on a weekly basis to identify themes or any patient safety risks.
Okay, thank you, Kate. Any questions for Kate? Nikki?
Thank you. Kate, sorry, just a quick question relating to self-harm, and I don't know if you know the answer or if Richard will need to come in, but you talk about the sort of lack of national PQ beds. So when you've got cases of high harm, needing to refer to a PQ bed, but there aren't any, and then we might have to increase specialing one-to-one and staffing and so on. I just wondered, do we get paid for that, or do we have to resource that ourselves? You have to resource it yourself.
I'm going to have to defer to either Jean or Richard on that one, I think, if that's okay.
Jean?
Yeah, so Jean's got a hand up.
Yeah, we have in our CAMS contract, we do have a specific element where we can cross-charge for any additional one-to-one support we have. It is limited. So there is a cost pressure associated with the number of complex children we've had specifically in the boroughs. Obviously for mental health, adult mental health, that doesn't apply.
Thank you.
Okay, thank you, Jean. Okay, Angela, you wanted to come in.
Yeah, just wanted to just pick up on the pressure ulcers, Kate, and clearly, obviously very clear in terms of our role in that, but just picking up on residential homes, and we know there's increasing pressure in these facilities, and I just wondered what across the system discussions are going on. If we're picking that up and both acutes are picking that up, what and how we're working with system partners on this, because obviously we've got winter coming up. Is there anything more we should be doing or we are doing?
I think we are having conversations with our acute colleagues in relation to pressure ulcers, and obviously linking that back into any CCG discussions in particular around this area. I think what we probably could do internally for us is really understand some of the devil in the detail around this, and understand the types of, the depth of, the depth of the issue. Is it centred in any particular one area? Those sorts of things, so we can really try and potentially focus resources, district nursing resources, etc., to support those particular areas and those particular care homes. So I think we are having those wider discussions in the system, I believe, and we are all seeing quite similar pictures in relation to pressure ulcers. However, I think we could probably do a little bit more detailed work within the TVN team around what that looks like for us and where we might want to focus those resources.
Okay, thank you, Kate. Angela, are you happy to leave that there? Happy with that? Okay, Jean, you want to come back in?
Yeah, it was just to add to Kate's comments really about the pressure ulcers. I think we did see a big spike. We had the care homes tactical force team that went in to really troubled care homes over a period of time, and obviously they identified quite a lot of issues within some of those care homes, which saw that increase. We've been working really closely as part of the care home cell within the COVID environment to do some additional training around pressure ulcer management within residential and care homes. Our TVN team haven't been specifically involved in that, but they have been providing some, they've provided some support to our district nursing team, and we have been offering advice and training into care homes through that tactical support team. And that will continue. That's part of the ICAM programme now. In terms of some of the key areas of quality and the quality framework that's being developed with the CCG. So I think it's an area of concern. It's been identified and actions have been put in place through the care home cell.
Thank you, that's helpful, Jean. So I think the fact that it's been picked up through ICAN, which, by the way, in case people haven't spotted it, ICAN is actually I can't remember what it stands for now, Jean, which is very bad of me, but it's the sort of brand we're using. Integrated care across Northamptonshire, which is the work that I was referring to earlier that the Cqs were doing. So it's being picked up as part of that and that approach, which is good to know and important to address. I just wanted to comment that I know that one of the things that came out of the discussion and the report on falls Moira, you helpfully highlighted, I think, a discussion that had taken place, or a report from Quality Forum to Quality and Governance about sort of falls data and falls initiatives, particularly because some of our governor colleagues have been very interested in that. So just to confirm that we shared a summary of that into a briefing that we sent to governors earlier this week, I think, wasn't it, Fiona, that we issued a briefing. So just to confirm that we did provide a bit of an update on falls reporting and falls initiatives to governors through that briefing. And the only other question, Kate, I wanted to ask is that you mentioned the PPE incidents that you're reviewing. The themes that you commented on, none of them refer to sort of PPE shortages as such. Is that right? So it's more about manufacturing issues and things like that that I think you've highlighted.
Yeah, that's correct. So we've had a couple of issues with some shields, for example, where there's been recall, but nothing in relation to shortages of either PPE or things like hand sanitizer or anything like that, which is kind of the things that we would really want to be highlighting very, very quickly. So, you know, it was good to see that in the review. I just also wanted to say that we've obviously been talking about pressure ulcers as well with the quality arm of the CCG, which obviously is slightly separately to the care home cell, but again, it's just a different way that we're trying to communicate with the system.
Okay, thank you, Kate. So if we've got no further questions for Kate, we're just asked to take assurance from that report around how we're managing and learning from our serious incidents. It's obviously part of our suite of standard reports. So finally, Kate, and then I think we'll have a comfort break after this item. I'm sure everyone will be wanting a cuppa of some kind. So we'll let Kate conclude this section with the Monitoring Workforce Safeguards report. So back to you, Kate.
Thank you. I'll take the report as read. Just a couple of things really, that staffing has been fairly steady during the month of May. We've had no staffing shortages which have been linked to incidents or SIs during that period of time. And we've only had one safer staffing escalation, which was in community nursing. Obviously, the report does note a slight increase in agency spend, which is obviously directly relatable to sort of COVID and some of the spend around medical support during that period of time. And also just wanted to highlight that we've started to plan to put back in place face-to-face mandatory training where there is no other option to do that online. So just wanted to say that that's also been agreed by the executive.
Thank you, Kate. The only question I just had about that increased spend was that, is that recoverable? I'm assuming that all our additional spend, or the majority, let's say, of our additional spend is claimable through our financial regime. I can see helpfully that Richard has got his hand up.
I was hoping his hand was going to go up, to be honest.
So I was aiming at it, Richard.
Thank you, Christine. I thought it was probably best placed to answer that. So in the current regime, which is operating till the end of July, all providers are in a place where we're topped up to a break-even position, so which is a genuine break-even zero position. There's various elements underpinning that. COVID is one of those elements. We are claiming additional COVID-related costs. We've got separate cost centres, so we're tracking all of that. And yeah, we haven't had any concerns raised around NHSE and I. They are asking quite a lot of detailed questions on a month-by-month basis, but yeah, we're paid up to date for COVID. So yes, we are recovering all those costs.
Excellent. Thank you very much, Richard. Scott, couldn't help commenting on the speed with which your hand went up for that one, but it was fully expected. Thank you.
Thank you very much. From the confidence and pace of response, Richard.
Yeah.
Okay.
Thank you very much. Thank you, Kate, for providing us with assurance on the range of quality areas, and of course Moira at the start of that section. So it's more or less 10 past 11, let's say, generously. So shall we have a break? Shall we have a 15-minute break? So would that be all right until 11:25? So bearing in mind this is recorded, I would suggest that colleagues turn off their video and their microphone, and then we will reconvene at 11:25. Thank you. Right, everybody, we're at 25 so I'm going to make a start, and for those of you who may have joined us, like Chris who's just joined us now, just to remind everybody that we are recording this meeting, and it is also live and being observed by several members of our Council of Governors. So welcome back to everybody. We're going to continue where we left off, and we're moving on to our finance and performance section. And we start with a couple of assurance reports, first of all from the Audit Committee and then the Performance Committee. So, Alistair, is there anything you want to highlight from your report?
No, thanks.
No, okay. That was brief, Alistair, thank you. Any questions for Alistair that anyone would like to raise from the report? No, everyone happy then that we've got good assurance from that, so thank you very much. And then secondly, the performance report. So Scott, anything you would like to highlight from the report?
Well, just briefly, Krishni, perhaps not quite as briefly as Alistair's just managed, but obviously made comments earlier on about the way that we view the organisational risk register, and the next item on the agenda is about the performance dashboard refocus, so I'll leave the comments about those there. A couple of areas that came into focus when we were doing performance last time. One was around the Northamptonshire shared care record. And obviously, I think, obviously as a board, there is a group of NEDs and beyond, we're very supportive of this activity, but what we felt was that we weren't perhaps cited in some areas on some of the ways that aspects of things like information governance was being managed in relation to the rollout of the shared care record. So that kind of prevented us from being sort of fully assured in that area, but very kindly Richard took the action to sort of go off and get some detail perhaps to help us in relation to that. So that's the reason why that's been marked as amber. And then just one other comment, which is in relation to some of the commentary you'll see under the Board of Directors self-certification declarations. First of all, obviously important and very reassuring at this time that we're able to complete the self-certification, fully and in that manner. But I think I wanted to draw attention to the fact that the Performance Committee was supportive of the intention through that vehicle to offer more training to governors in future. So I think important that we continue to seek to offer support to our governor colleagues through that route, and I just wanted to draw our attention to it. And that was it, Krishni.
Thank you. Oh, thank you, Scott. Any questions for Scott that anyone wants to clarify? Okay, so Fiona.
So it wasn't particularly a clarification on the report. It was just more to respond to Scott's note about training and development for governors, and that's obviously something that we're very interested in as well. And we're looking at actually doing some sort of specific work on what training do they need as part of an overall plan for the Council of Governors that we shared an outline of in the last Council of Governors briefing document.
Thank you, Fiona. Okay, so we'll note that report and note the assurance provided by both those reports. So the third item under finance and performance is our dashboard, which is a new format. So Richard, did you want to comment on this?
Yeah, I think I'd just like to take through a few bits really. So as was discussed at the last performance committee, and there was very overwhelming support to try and refocus the dashboard given the very different operating environment. So I suspect this may well prompt a few questions and is clearly still sort of work in progress. And I'm very grateful to colleagues who have supported us trying to be agile and trying to get relevant information in front of the board. One element just under the kind of COVID-19 section, I think I'd probably defer to Kate's report on learning from deaths, which probably has a much more comprehensive picture that we heard earlier in the board than we've captured in the area here. We've included a range of items, so PPE obviously is very relevant, and we thought it was useful to include the kind of overall stock levels and kind of usage information that we've got. Also under health and safety, you know, a lot of work has been done, further work being done around kind of COVID-19 secure areas, with none of those as yet fully signed off across the trust. And then we've included a whole range of health and wellbeing indicators, including some information in the appendices around sort of annual leave taken, analysis across Black, Asian, minority ethnic groups. And then within the finance and performance section, I think again, as was referenced earlier, we are not unsurprisingly spending additional money on agency and bank compared to a year ago. And some of the more routine kind of performance targets clearly are not being met, as you would imagine, in the current COVID environment, given all the pressures that there are. So shall I pause at that point? I'm sure colleagues will support me in any questions that are going to be raised, but also welcome some feedback on whether this is meeting the kind of needs that people wanted to see in the current environment.
Thank you, Richard. So Scott would like to come in. Scott?
Sorry, Kirsten, just trying to come off mute. Yeah, so I think it's a good first pass, Richard. You know, I think certainly it feels like it was representative of the discussions that we had at performance, because clearly some of the elements that were contained in the performance dashboard as was just felt a little bit out of touch with our current reality. So I think that the focus contained within this is helpful. I'm going to defer to exec colleagues to talk about any fine detail of elements that could or should be sort of higher priorities, or perhaps that might be gaps or anything like that. And I think directionally it feels like, you know, a much more appropriate and current view of performance, and something that I think we should be focusing on going forward. So well done to all.
Thank you, Scott. Couple more comments, Nikki and then Melanie.
Richard, I was going to say, I find it quite helpful to sort of, you know, have a look at it and see if there's any areas where, you know, want to look kind of further, which just leads me to ask the question, really, on the finance and performance stuff. In the acute sector, there's a lot of pressure on getting back to normal, you know, outpatient appointments, services that weren't done during the COVID kind of thing. And I just wondered, are we helped to put additional finance into those areas where we're not meeting our targets, so that we can kind of pick those up? Because understandably, we've had to, you know, we've gone backwards a bit during the COVID crisis. I just wondered if there was anything there.
Yeah, so a couple of bits, and then I mean, Jean may want to comment as well. I mean, firstly, I think we've been less impacted in terms of overall levels of services. So our services have very much continued across most areas. Lots of things have switched from from face-to-face to non-face-to-face. So, and the acute trusts, as you say, the DGHs have been much more impacted in terms of reduction in elective activity. Certainly areas like ADHD that we're referencing on there, we are progressing recruitment, supported, we expect, by the Mental Health Investment Standard, because although we haven't received additional funding as yet, there is lots of very positive promises around that. So we are actively making sure we have got the appropriate capacity for that. I'm sure Jean will probably want to comment on some of the recovery work that's going on.
Jean, I'll just bring you in here on this particular point.
Yeah, so I think it's a really good point, actually, Nikki. So that we have been continuing to do the majority of our treatment as much as we can using digital and alternative solutions and technologies. There are some services such as MSK and diabetic high risk foot, for example, that are increasing risk because we've been unable to see those patients. So we had a meeting on Tuesday about what we're going to do and how we can really start to increase those activities. Obviously, the delay in some of those services starting back has been to ensure that we've had a COVID secure environment. So that's now all progressing quite quickly. So we're expecting to get some of those services back up and running. I just wanted to highlight to the board actually in terms of the adult ADHD service, how remarkable and well they've done in terms of reducing their waiting list. So whilst we're not back up to the 92% standard, there has been an 84% drop in the number of patients waiting over 18 weeks since December. So that is due to them and real focus on that. So I think it's really great, and we've got some more work to do. And I'm just wondering whether in the meantime it's worth perhaps expanding this to include more information around waiting times, because I think it's something that actually I believe the board should be aware of in terms of where we've got trends and improvements or areas where we're sort of seeing an increase in activity or an increase in demand.
Thank you.
Thank you, Jean. I think the board, I'm sure the board would welcome that, Jean, where that's felt pertinent to highlight those challenges that you might be facing, or significant improvements that you want to bring to our attention. So I'm sure that would be supported. Angela, did you want to come in on this point, or is that a separate one? Okay, I'll bring you in.
Yes, just importantly, again, thanks, Richard. I think it's definitely demonstrating the agility, which is important. But in terms of the waiting list, I agree with Jean. There's lots of great work going on, and we want to take the opportunity to thank operational colleagues for that. But I think there's also going to be a need for us to understand at the board where we're seeing referrals not coming through, and actually that needs to be also a lens that we increasingly look at, because, and Moira talked about hidden harm earlier in the board, we have seen some impact, and I think we just need to stay close to that. I know people are staying close, but I think the board will equally want to stay close, because primary care has changed in its working with populations, and I think we should be equally aware if we're seeing trends in that direction as well. Thank you.
Thank you, Angela. Okay, now we've got a couple of other non-executive directors wanting to come in. So Melanie.
Hi, yeah, just a couple of questions, Richard, I guess, maybe just a couple of things that can be expanded within the appendix. I was interested in the health and safety site risk assessments, but the one-liner on the performance dashboard is a bit of a blunt instrument. I don't know how many health and safety risk assessments are ongoing and how long they're taking. The risk being that they're taking too long to sign off and act on. So I don't know if there's some way that we can maybe expand just a couple of metrics behind that to demonstrate number in progress, number signed off, and just understand any risk that might be emerging there. Equally, with the individual risk assessments completed, again, it's a bit of a kind of a one statistic, whereas we know we've obviously got, we are trying to do everybody now, but there were particular pockets that are particularly important, and it might be useful just to try and understand in the appendix, as you've done with self-isolation, a bit of a pie chart process to sort of say, here are the particular sort of protected characteristics in particular that we're focused on. And finally, I just wondered whether it was helpful or not, because we don't want to add insight into this just for the sake of it, but I'm conscious there's no real patient feedback measure to see whether patients themselves, whether we're seeing a deterioration in patient experience and patient satisfaction. And I know that's incredibly difficult because you have to look to I Want Great Care or PALS really for that kind of evidence. But I wondered whether there was something that we could think about that just provided us with a temperature test of patient experience to see whether the continued pressure that the staff are under, the brilliant job that they're doing, keeping it all going still, just again to monitor for any risk that's actually affecting the level of care we're providing. So I haven't got an answer for that one. I was hoping somebody else could come up with the answer. I just had the question.
Richard, I think Richard and Jean probably both want to respond to that. So Richard first and then Jean.
Yeah, thank you. No, it's really helpful to have the feedback, and certainly there is like patient feedback we'll take away and review. And as you say, one line doesn't always do justice. I mean, we had a big moderation process, otherwise the report probably wouldn't have been ready till next week. So as you can imagine, there was lots we could have included, and we had to limit to make sure we'd got the report complete and out to people. But we can certainly take those points away and reflect on how we expand that with colleagues to support that.
Okay, thanks, Richard. G?
Yeah, just in the individual risk assessments, there'll be an update in the flash report that will come to you tomorrow. And we have all of the information in terms of which areas have been risk assessed through the COVID secure process. And I'll speak to Angela to see how we can get that information over to you, Melanie, because I'm certainly happy to share all of that.
Okay, thanks, Jean. Yes, I think that there's been a regular inclusion of the percentage, certainly progress on certain protected characteristics in our flash report. So it's whether we feel it's appropriate to include here. I think I Won't Break Care has just restarted, hasn't it, or about in the last month. So potentially that's there, will be there again as a sort of easy indicator, if we like, in terms of patient experience. Maria?
Yeah, thanks, Krishni. Just two things. One, sort of following up from what Angela said about understanding the impact of COVID on our services. I wonder, and I'm guessing this is probably happening at a system level, and I think that's maybe where it needs to happen, is seeing the impacts of things like the delays in elective care for patients, what that's going to mean for our services in terms of planning, where people are going to be waiting a very long time for things like hip knee replacements, those things, so that we're planning ahead for that. And it would be good to now we're so many months in, to be able to sort of take that stand back and look at the whole picture. And as Angela said, where we're not getting referrals, but also where there's going to be pressures building up in the system, and just to get an understanding of what that's going to be like. And the second point was about it's not maybe the right place for this on the dashboard, I don't know, but it's around transmission of COVID infections within the trust. How would we pick those up? How would we report them if that was happening within the trust, so that we would be aware?
Okay, does anyone want to comment, Jean or Angela?
Yes, I think importantly, we are still waiting the phase 3 guidance letter, unless Richard's received it, and but I think, you know, we're due by the end of July, so it's pretty imminent. So I think we need to use that as a little bit of a springboard around, as you described, Maria, what the priorities the system need to, what's the expectations on us as a system, what do we understand is going to be the next phase, and then obviously how do we support that. So I think that is something we will actively do, and the recovery group that we have internally, as well as the system one, will be taking stock of all that. And I think, again, in due course, we want to share that with board in that respect as well. I think in relation to any sort of clusters or outbreaks, then obviously we, Julie and her team are very much active. We've got our test and trace system underway as well internally, and we've also got the flash report to the board, where we do seek to give any updates if there is obviously information emerging in any of those areas as well. So there is a very clear mechanism, there's a very clear process, and we will seek to use the flash report to keep it very timely for board as well.
Okay, thank you. Jean, anything to add to that?
I think it's just about the activity levels and what's happening in the acutes in terms of elective activity. Obviously, we do discuss that at Cqc every week to try and get a bit of a sense in terms of what's happening. We have seen an increase in referrals into continence and MSK because of some of the activities not happening in the acute. So we are trying to keep an eye on it and monitor it. And some of that information has then been fed into the acutes in terms of their prioritisation into the clinical prioritisation element within what they can do in there. So we are trying to do it, it's just not being done in a structured format. And as Angela says, when we get the phase 3 letter out, we can then start to do that in a more structured way.
Angela? Want to come back in?
Yeah, sorry, I just thought, I just finished there, that I think it's also important to share with the board that we are seeing an increased acuity in our mental health sector, which is significant and one that we're talking about locally and regionally, you know, and that is an increasing level of psychosis, but also people who are perhaps presenting to mental health services for the first time. So I think, again, importantly, and I know that the board will want to know that we are looking at the demand and capacity with our regional colleagues, because this doesn't exist for mental health sector, and we're hoping most certainly this month, again, we've got some discussions tomorrow in the East Midlands Alliance where we're talking with the National Director Claire Murdoch around that. So again, will there be another way of looking at it, not just a local one, but also regionally, are we in a different position, or how do we plan with our system colleagues about that demand and increasing expectation of demand in mental health services too?
Okay, so I think we've had a kind of long, helpful discussion on points of some points of detail. So some suggestions about maybe some additional areas, Richard, for inclusion. But I think overall, I think the new content is welcome and adds a picture to the board over and above what we already get in terms of regular flash reporting from you all with regard to COVID and the management of it. I think going right back, Richard, to the point you made at the beginning, I just thought it was worth sort of noting really that the report, the dashboard clearly gives a COVID related deaths figure, which is somewhat different to the figure that Kate provided, but it's probably just important to recognise why there might be that difference. So I think Kate did say a couple of times that the figures that she's been looking at and that we looked at from Learning from Deaths report was actually multi-agency. Am I right in understanding that distinction correctly?
Yes.
Kate might want to comment first.
I think as well, what we've got is what was reported on Datex as well, and then the extra ones we've found through discussions with our colleagues across the system. But and obviously deaths are reported into us in a number of different ways, and so we've obviously got the Datex figures, and then once we've done a deeper dive, we've found other deaths which were related but perhaps weren't highlighted as such on Datex or have come in through a different route.
Yeah, okay, thanks.
I think
Kate.
the ones on here, Krishni, will be, because they're from the National Sit Rep, will be kind of inpatient related.
Yeah.
In the broader picture. So we'll clarify that between Kate and I, yeah. Yeah,
it's just, I think, helpful because I was kind of considering that a casual observer might think, well, there's a bit of a difference between what we talked about earlier, so it was probably worth commenting. Angela, did you want to come back in on a point or no? Okay, that's just up from earlier. And I think the only other thing I just wanted to observe is an important point, because I think we've shared this with governors as well, and I've heard the regional director saying it, so it's probably worth just sort of commenting on this, that when colleagues talk around the country talk about restoration, our regional director actually commented that pretty much mental health trusts can say actually we're not restoring because we didn't stop doing them, didn't stop providing. So, I think it's a really important point that our core services have continued, albeit differently. And therefore the word restoration doesn't apply in all cases across all services. And it's a very important point, I think, for people to recognise. And that is different for different parts of the NHS and different sectors within the NHS. Okay, so I've got nothing else to cover on this particular section. We're going to move on to the accountability and assurance section, and the first item we have is a framework of quality assurance for responsible officers. And I note, actually, we didn't note this at the beginning, that Alex O'Neill-Carr, our medical director, has sent his apologies. So Richard, is someone else covering it? As in Richard Smith, sorry.
Sorry, Christian. No, we haven't I identified somebody else, as we didn't realise until this morning Alex wasn't here. I don't know whether any of the colleagues that attended Q&G, where the report was presented, may be able to cover.
But Christian, I think importantly, I'm assuming people have read the paper, but in essence, what it's about is confirming to the board that the normal processes have been affected by the pandemic, and that is clearly understood by the board, but framed here. And then most importantly, the sort of confirmation of the fact that NHFT remains compliant with the process that are expected, which is obviously the important assurance that the board would require from Alex.
Okay, thank you, Angela. I can see Moira wants to come in, but I think probably just recall that right early on when we were talking about easing the burden, I think the guidance that we received from our regulators, there was clarity about the sort of the expectations around medical revalidation and the changes that would be acceptable in this period. So I think the paper just reflects that, but the submission is our annual submission as normal, reflecting those changes that were approved nationally. Moira?
Just to say that this did come to Q&G in June for information, and we were assured by the compliance when we saw this paper back then.
Great. Thank you, Moira. That's helpful, and I don't think we need to consider that further, other than just to support the fact that it's submitted for. It may well have been submitted already, but we do need to, I think, formally record our approval for that submission. Okay, thank you very much. Moving on then to the next item, it's our regulatory report on equality data, and I think Richard Smith, we've got a number of guests joining us. Are they with us already?
Let me just check.
Is it David who's leading this item, David Ledger?
It is, yes. Let me just invite them to join. Just bear with me a second.
I was just going to introduce it if you want, Christine, and then...
Yeah, so while Richard's doing that, let's get Chris to just introduce it to us. Thank you.
Yeah, so we've got 3 regulatory reports we have to do. We have to report on RES, the Race Equality Standard, WDES, the Disability Standard, and gender pay reporting. I think overall the summary would be that we've made some progress, but we've still got some real challenges and things that are unacceptable. And then probably I would want to highlight the areas of action that we're talking of undertaking. So if we just draw some highlights out, the overall recruitment in the RES has improved, and we've improved on some of the higher graded posts. Very frustratingly, the recruitment seems to be quite resistant to change, and I'll come back to that in the proposals of what we really want to focus on. And that remains again at an unacceptable level. Disciplinary and disproportionate impact there has improved again, and historically that's been much higher. So that's good news and improvement, but still isn't at an acceptable level. But I think the lesson from that is that our cultural ambassadors have made a huge impact there. So that type of initiative, which we want to apply to recruitment, we think is really important. On the disability, recruitment has improved and has capability, but the capability is still at an unacceptable level, although the recruitment's reached the standard, which is positive. And very interesting that 5% declare disability, but 21% do so in the staff survey. So again, I think we are seeing some response to the profile we've given to supporting the disability network. And on the staff, I think on the staff survey, going back to the RES, that is again one that remains really difficult, the bullying and harassment, all those issues, and one we need to do a lot of work on. On the staff survey for the disability, we've had more staff reply, and again we've seen positive improvements about reasonable adjustment and people feeling their work is valued. And then the final area is the gender pay gap, which is again I think really mixed. In some areas we've improved, other areas we haven't. We have done events this year, so we had a women leaders event, and we've supported a number of things to target this, but I think the key area we need there is we need a lot more analysis. We do this periodically, but I think we need to commit to just understand an awful lot more of what's happening underneath the figures that we're getting and how we can do things to develop that. I mean, and particular things have historically been inherent. So the fact that there are more male medics and we have bonus awards for them, and so that's likely to be disproportionate. And then I think the final summary for it is the things we want to focus on are one, the kind of bullying harassment with patients, which is a key element. We want to put recruitment experts in, which is like putting the cultural ambassadors into the recruitment. So for every post above band 6, we'd have a recruitment expert who would be able to give input to that. And also working, again, this has been discussed with the staff network leads and with Jean and Sandra, and particularly we want to really focus on a in-depth learning for managers across the trust as a key element. For disability, we've done a lot of work on the health passports. That needs to continue to progress. And then reverse mentoring is another key element. And as I said on the gender pay gap, it's about analysis. So it's about trying to get some really big chunky things we think will make a difference and committing those to take them forward. As we said, we've discussed them with colleagues from the network, so they have been co-produced in outline, but clearly our whole focus on responding to this will be, as we have previously done, to work with them to co-produce the way forward.
Okay, thanks, Chris. I'm conscious we've now got, according to the record on the participants, we've got David, Doris and Patsy joining us. So can I just first of all welcome them to the meeting? I'm hoping you hear us all. It'd be lovely to see you, but I can't see you all on video. So are you there?
Yes, I'm here.
All here.
Great.
What we were hoping to do was just to give, as Chris has outlined, some of the workforce metrics are heading in the right direction, but recognise we have some work to do. But it's the experience metrics that come through the staff survey that give us greatest concern, and we felt it would be useful to kind of share some of that. So we're going to have Doris just to share, and Patsy from our BAME network to share some of the experiences of colleagues, and Natalie from our disability network just to share how we support colleagues through this recent pandemic, and just to give a flavour of what actually is the story behind that data that Chris has presented. So Doris, do you want to maybe give an outline of your thoughts first? Oh, we might have lost Doris. I suppose, Natalie, do you want?
I don't think.
No.
I think we might have lost her.
Maybe why Doris rejoins then. Natalie, are you happy just to give a bit of an overview of the support that you've been providing with your network through the pandemic?
Yeah, so one of the things we did was we set up a weekly online drop-in where people can come in, share anything they want to in a safe environment, made it quite psychologically safe. As each week's progressed, we've picked up on themes. So in the early stages, we talked about emotional first aid kits, using the health passport, doing the risk assessments. We talked at length about that. As the weeks have progressed, we found that we get themes coming up. So worries about a certain group or groups of people. So there was some concerns about shielders who couldn't link in with us. But then last week, what came through quite strongly was about people who are hard of hearing and how they're coping with masks and, you know, where they're working, how they're working safely. And we've had some members step up and share their techniques or anything they can use that aids them at work. So it's been really quite useful in sort of gathering thoughts and feelings, and also helping formalise other people's worries and kind of setting them to one side. So it's quite a supportive environment we've found, which requires very little steer or coaching in any way. People have been quite readily accepting of it, so it's been extremely useful in that way.
Great, thank you, Natalie. Do we want to take questions at all Or should we let's do everybody and then come back if it's all right, Nat. We'll just let everyone else. We'll let Doris and Patsy speak, and then we can just take questions in the round, and everyone can take part in that if that's all right. So is Doris with us now, or should we just go to Patsy?
I am sorry about that.
That's all right, Doris. Don't worry. Nice to see you.
Nice to see you. Hi, everybody. Right. Okay. I guess for us, it's it's been a bit of a roller coaster really for the BAME network, but we're getting there. We're working together, so we are getting there. We looked at the data, the bullying and harassment side, and I had a colleague actually who had quite an interesting view or perspective of bullying that perhaps we might not see as obvious bullying. Unfortunately, due to her workload, she's not able to come and share it today, but she has given permission for me to share it. Basically, in her department, she, due to having an operation, she's a health visitor. Due to having an operation, she was moved to one of the hubs to take the calls as a way of supporting her with her health and the changes to her health. So the idea was that she would take a lot of calls. Now, she starts off her day with 20 calls already waiting for her and can do up to 40, 50 calls. Bearing in mind that this is in relation to children. So obviously each call is it's not just going to be a 5 minutes thing and then signposting and going back to check. Her workload, as she said to me, was too much. She said it's getting so much that she's actually sometimes not finishing work until at least 6 or 7 o'clock in the evening. She has mentioned it, she did voice it out, and as a result of that, 2 health visitors come in, I think twice a week perhaps, but they've made it quite clear that they can only take on 4 calls within the time limit that's given. So again, she's left with it. And she feels like to sort of, I'm gonna say as if it was me saying it, because that's the way she put it across to me. Yeah. I feel like I'm judged by the amount of work I do, not by my experience, not by the quality of the work I do. And if at the end of the month we've covered 300 and something, an email comes around saying congratulations to all the team for doing it, and I sit there thinking I did 300 and something of that by myself. And she just feels like the couple of times that she's tried to mention it, she's the only BAME worker there. She then feels even more isolated, like she's trying to rock the boat. Everybody's doing their bits, kind of thing. And almost like, well, we've moved you there because we've already supported you. And it's just heartbreaking, because she said I can't say I'm being bullied, but I feel like, surely they can see that this workload is incredible for one person. But somehow she didn't raise it anymore, because then it would look as though she's complaining or not doing her part or whatever. But she said it's not exactly helping the health side of it that was meant to be to help her. So it was just it was a very subtle way of looking at a bullying harassment that on the surface may not look like it is, but for that individual receiving it feels very much like that. Yeah. Okay. Yeah. So that was from a personal story. Okay.
Yeah. Thank you, Doris. Thank you for sharing that. Well, we're also going to hear from Patsy.
Yes. What I'm going to present is some work again that another of the committee has been doing with bank staff. Millie, she's been trying to support some of the bank staff, and she's produced a document which I'm going to try and share, if you bear with me. Hopefully you can see that. So it has been anonymised, but basically, it's the experiences that some of the bank staff have had. The membership has increased quite a lot in the network recently, and quite a lot of the bank staff have joined. But they're saying things like that they're not being included in things. That sometimes handovers are not being done in the right way. They're not getting the information they need. Sometimes there seem to be certain cliques in areas that, you know, it's not an official thing, but they feel as if they'd only get booked onto a certain ward if they know somebody who's there, that kind of thing. Other times they're feeling afraid of speaking up if there's an issue that comes up that they feel they should speak up about. They feel they'll suffer detriment if they do, and that's actually happened, that, you know, somebody might have raised an issue and then it sort of comes back on them, and they get accused of something and end up not being able to work on that on the bank for a while. You know, they're suspended while an investigation goes on, but then it turns out that accusation isn't upheld, but then the damage has been done already. So as you can see, there are several instances, and you know, it's not just one or two people. It's been quite a few people. Even some people have said that there are certain areas that they don't want to go and work in, even though they live right next to that area. They'd prefer to travel to the other side of the county to work in a different ward, because, you know, they don't want to go back to a certain area. So yeah, that's some more examples of unfair treatment, really.
Thanks, Patsy. And that's the examples there are all specific from individual members of bank staff, is what you're saying?
Yes, yeah, that's the piece of work. I think it does, you know, it does happen with substantive staff as well. That this particular piece of work was staff, and I think it as well, the fact that there are so many bank staff rather than substantive staff, that's an issue as well, about why they are bank staff and not, you know, there are some that have been working for a long time on the bank. So another issue.
Thank you very much, Patsy, and thank you, Doris, as well, for sharing those. So I suppose my you know, before we kind of move on to talk more generally, I just want to know that there's a way in which we're picking up that feedback and addressing it. Obviously, it wouldn't be appropriate for us to discuss individual circumstances here today, but have we got a mechanism for, you know, making sure that those concerns that are, or experiences that people are, Doris and Patsy have described, David, for picking those up and addressing those issues?
Yeah, so we have two main links in which we do that. We have good links with the BAME network directly into HR, and then we have Freedom to Speak Up champion from a BAME background, equally, so that staff have the confidence to raise concerns in that area. But yeah, we'll work with Patsy and Doris just to address those concerns that have been raised today.
Yeah, thank you. I think it is important, that feeling of exclusion that was described, and you know, being afraid to speak up or fear of detriment, all these things are things we absolutely recognise need to be addressed. So it's important that people feel confident that we would take those forward. I can see there's some comments and questions that people want to make. So Angela, I'll bring you in first, and then I know Maria and Scott are waiting. So perhaps Angela, you'd like to comment first.
Yes, firstly, just to say thank you for Doris, Patsy and Nat for joining us, and David today, because again, I think what we're starting to see now is increasing people join the networks, which is fantastic, because now we're getting more of the voice, which, you know, whilst many things are very unacceptable, and I wouldn't want to sidestep that, I think the voice coming forward is the powerful piece, and I really value that. But the important thing is how we work together, and I know we've started some of that. I think what your contribution to the board today just reminds me about how much more we've got to do, and I think that's really helpful. And you know, we committed to that, but we've got still a lot to do. And then I think the other thing that I would just want to suggest through quality and governance is we do look at bank staff as a key line of inquiry, because I think we've had elements come through before. This is helpful and some new material, but I think it would be useful if Quality and Governance looked at bank staff and, as you rightly say, Krishni, the inclusion and the value piece, because what we're describing and we're hearing through all the networks is, do I feel valued? Because that's what an inclusive culture is about, and I think it'd be good if Quality and Governance looked at that.
So that's something we can perhaps ask colleagues to take away. So I know there are a lot of questions and comments, so if I can just pick those up in order. Maria first. I know, Maria, you've been waiting for a while, so I'll bring you in.
Thanks, Krishni. So I put my hand up, sorry, before colleagues spoke. So it was so helpful to hear the feedback from staff in terms of starting to understand what lies underneath the data that we've been concerned about for so long. So it's good that staff have been able to share those experiences, but also obviously very concerning in terms of what those experiences have been and the long-term impact that's having on people and will be having on patients as well, in terms of staff not wanting to work in areas and the impact that that has. My question was going to be around something that was in Angela's report about becoming an anti-racist organisation and what that will mean and how that will help us to address these issues. I wondered if Angela could say a bit more about that.
Yes, certainly. And I think it's really timely, actually, because I think there is a natural expectation when you put out messages like that for us to suddenly get on and produce an action plan, which is what I'm resisting us doing, because I think this is a real cultural piece. And just if I look over here in my office, 3 books have arrived on my table yesterday. A lot of reading going on in terms of what that could look, feel like and should be inclusive of. So I personally are doing a lot of reading around that. I also, interestingly, had contact from one of our bank members of staff who now lives in Canada, who emailed me following my message out, and I had a call with him in Canada last week, who also wants to join us in terms of our journey, which is fantastic. But what we're going to do is to take it in phases, and we've set up a meeting in August to bring people together, because we're doing this across both organisations in NHFT and LPT, because we've got that transformation and both organisations are committed. So bring a group of people together just to explore what are we doing now, because what I'm conscious of is that nobody sees what we're currently doing as a collective. And I don't want us to rush to what are we going to do next. I want us to take stock together about what is it we are doing and to get some sense about, well, what does that tell us about what is needed going forward? So that's already planned, but it is, in my head, a phase of just thinking of the cultural piece, thinking about how we're going to take this forward and not just doing immediate actions. So that's where I'm at.
Thank you, Angela. I'm conscious, Doris, you want to come in, but I'll just bring Scott in and then we'll bring you back in a moment. So, Scott?
Yeah, hi. Thanks, Krishni. Just following on, I think, from one of the comments that Angela made a minute or two ago about key lines of inquiry. I think we've seen the annual staff surveys give us, concerning, Chris used the term unacceptable earlier on, concerning results in relation to the res orientated questions each year, and despite our focus on that, we just never seem to entirely crack it. And I think perhaps some of the materials that Patsy was taking us through a minute or two ago give us a bit of a different insight because of the anonymised nature of the way that the questions are phrased, and also the fact that the questions in the annual survey cluster aspects of bullying and harassment coming from other colleagues alongside patients. The sorts of materials that Patsy has brought forward perhaps give us a different, fresh insight on that, and that key line of inquiry approach would be helpful. I think it's really important, though, that our BAME colleagues know that they have our full support, and that these sorts of behaviours coming from patients, even in an environment where, by a very nature of the patients and the service users that we have, they can obviously be in a distressed emotional state when we are providing service to them, but that still doesn't excuse aspects of racially motivated bullying and harassment, and our BAME colleagues need to know that we're going to stand with them in order to be able to take that on and address it and understand how we can improve that. It's just not acceptable that we should be asking them to tolerate that in this day and age.
Thank you, Scott, and I'm sure the board would fully support that comment from you. Doris.
Okay, I just want to say, actually, Scott, this is coming from how staff are being treated by staff. We haven't even begun to look at the patient side of things. But just to sort of put a little bit of a positive spin into it, I think that some of the difficulty has been that areas where people, the services that we've got where people can speak up have not been diverse. So it's, you know, to put it bluntly, it's me going to speak to yet another white person. Are they going to get it? Are they going to understand where I'm coming from? And, you know, and what's happening with the bank staff specifically is that people are seeing things in relation to patients that are not right, calling it out, and then becoming the victim of that. So that's where those comments are coming from. But we are working on it. The BAME network, as Patsy said, our numbers have doubled. We've got over 200 members now. 4 members of the network have been put forward, names have been put forward to train as champions to sit with freedom to speak. So I suspect these figures will get worse before they get better, as people begin to find their voices. So just be mindful of that.
Indeed.
Yeah.
Okay, thank you for that. That was really helpful. Sorry,
Thanks, Doris. I think it's a really important point. I mean, it's interesting, isn't it? Because I think the staff survey, I think there was also a note in there about the number of BAME colleagues who actually completed the survey. And in itself, I think Doris makes a really important point about the more I think, and it's Angela's point about culture too, isn't it? Because in the end, we've got to enable people to speak up and to share their experiences and talk openly and feel comfortable. And actually, therefore, in doing so, it will get worse before it gets better, because there will be lots more for us to address. And the more people feel comfortable to speak up, the more we'll hear that. It might make our results look worse, but the important thing is we're hearing it so we can do something about it. And I think that's in itself a sort of, it's an important point, isn't it? Because unless we hear it, unless we create a culture where people feel able to speak up, and they're confident they can do so without detriment, which I think were the points that Doris and Patsy made right at the beginning. Actually, nothing changes, and that's really important. Melanie, and then Chris.
Hi, yeah, I mean, taking the point very much around the environment is not yet diverse enough. It's disappointing to see that the res metric 2, the recruitment statistics, haven't materially moved. I wondered, and this might be a question for David or Chris in actual fact, whether we can evidence an increased number of applications from, are we attracting more applications and just we're still struggling with the actual conversion into people getting the job, or are we not even seeing an increase in applications from a more diverse, and not just BAME in fact, but across a more diverse set of characteristics?
I think well, as you see in the report, the numbers of BAME staff have increased, and they are increased in the higher groups, the higher grades. So I think we are going in the right direction with that, but more to do. I think the key thing that we've learned is that, the disciplinary figure was the worst. I think, David, when it started, it was 4 times. And it's actually, we're all very clear, I think, that the involvement, champions, freedom to speak up, but champions, cultural ambassadors on the disciplinary panels has completely changed the perspective on things. And we've had some great learning there about how people perceive things, and even the way people, I think Doris's point about just how you manage, say, bank staff and often BME bank staff, people maybe just don't give them the support that they might give, white colleagues who are a permanent member of the team, and that needs to be seen because that might influence things. So huge learning there. The big commitment, and it's why we said we want the board to see the headline. We really think that putting recruitment specialists, and this means in effect cultural ambassadors in recruitment, on every panel at band 6 and above is a huge commitment, but really we can't see how you're going to change it until you do something like that. And before your point, Melanie, I want you to just endorse what Doris has said, because clearly it can be frustrating we're not seeing the improvement, but I think the numbers who responded to the survey increasing, and I'd echo what Doris is saying, more people are getting involved. And in a way, I think we have to own it. And it's, do we understand it? It's until you do have a mass involvement from BAME colleagues, BME colleagues, you're not going to get the full picture. And I think what has been said by Krishni and Doris is we are probably going on a positive direction of getting that involvement. And it's when we get that full involvement that we'll get the fuller picture and align to some of the things we're suggesting we should do, which need to be maybe one or two that really make a big difference. You know, then I start to feel we might, you know, I suppose Angela's saying, then we might move to an anti-racist culture as we start to do all that work.
Thank you, Chris. I think I just wanted to make a couple of comments. I mean, that there is something about making sure, just on the metric around the board and the board diversity, that we brief governors, because governors obviously play a part in recruitment of NED, and we need to make sure they understand what we're measured against in terms of board diversity and what that means in terms of trying to make sure that, you know, our processes welcome people with different protected characteristics. So I think that's one thing I just wanted to comment on. The second thing I was just aware of is that there is some work done by the CIPD about developing anti-racism strategies, and I hear, you know, I absolutely agree with Angela that we don't want to, this isn't about a quick, these aren't, you know, these aren't quick fixes, these aren't, you know, click your fingers and you can change that, but there is something about thinking about a strategic response to this, and a statement that I think, which Angela's already made on behalf of the organisation, but I think it's really important that we also reflect that with something that we're actually going to do. So I think it's a challenge for us to develop, to build on what we've already started doing, really. So Angela, I'll bring you back in there.
Yes, no, thanks, Krishna. I mean, I think you're right. I mean, what I'm hoping we'll get to is a strategic framework through which some strategic themes are clear and, you know, hopefully enabling for us all. But I think it's important to say as a board, and I know everybody would support me in saying this is unacceptable. And actually, that's the message that we need people to hear. It's unacceptable. And actually, we feel no different from that from this morning. And if that's not being heard, it's certainly what we feel. So I think that's really important to say. A couple of other things just to say is that with our Buddy Trust in Leicester, they are starting a Res Cultural Change programme with a national team next month, which we'll obviously in that partnership have an opportunity to benefit from, which is, I think, going to be useful because they're going to do a whole raft of in-depth diagnostic and detailed data, which we obviously do some of, but we would welcome to understand that. And I think already Doris and colleagues have linked with LPT colleagues, which has been fantastic as well, because support and all of that is generating the voice in both organisations. So thank you to colleagues for that. And we mentioned earlier before you arrived the South Asian heritage work that's been going on across both organisations, and I know you've been, you know, involved and instrumental in supporting that. So I just want to say thank you for that too.
Thanks, Angela. Yeah, so, you know, lots to do, and I think we would absolutely support what Angela said about, you know, making policies and the fact that, you know, some of these behaviours that we are hearing about and have heard about are clearly unacceptable, and we'd want to do everything to address them, and we want to obviously work with the networks, and not to forget, you know, Nat's on the call too, that the Disability Network and all the networks play a really important part in helping us with that. And I think it's been encouraging to see the sort of well-being focus that the networks have had through the pandemic, and I know a number of us have been involved in various listening events, etc. So thank you so much, everybody, for joining us, particularly Doris, Patsy and Nat. David, anything else you also wanted to add before we let you go?
No, just to echo the sentiments that everyone shared about the more work to do, but we've got good foundations to build on by having good involvement from our networks.
Excellent, thank you. Angela, did you want to come back in, or was that your hand up from earlier? Okay, okay, great. Okay, thanks, Patsy, Nat and Doris and David. Thanks ever so much for joining us again, and good to see you, and look forward to catching up with you again outside of the meeting at some point.
Thank you.
Thank you.
Thank you.
Thank you.
Okay, we're on the final straight of the items on the agenda. So just wanted to refer to the report from the Council of Governors, which is the which I think most colleagues here actually attended that meeting. So it's really there for your reference. Obviously covers all the membership changes that we'd recorded since the previous council and the areas that we discussed. I know governors were particularly interested to hear about freedom to speak up, and we've heard a little bit more about a sort of connected theme to that, which is expanding the Champions Network to make sure that actually it really reflects the range of protected characteristics. Because I know one of the things we heard from Matt that day was actually the the fact that when Diana Belfon became involved in that role as a Freedom Speak Up champion, the significant increase we had in concerns raised by our BME colleagues. So important, a very important thing. And I also just wanted to reference that. Can I just bring Fiona in here to just touch on some of the workshops that we're going to do with governors?
Of course. So we kicked off a really enthusiastic and energetic session with the governors, which we are looking to continue over the summer. We had a really good update from Sandra on the Trust's overall recovery journey, and within that there's obviously some recovery work that we need to do with the Council of Governors. And we started off with a workshop on membership and representation, and we're following that up with some more detailed workshops over the next 2 to 3 weeks, with a view to bringing a report to the Council in September for its consideration. Now, running alongside this, again, the other key duty of the Council of Governors is actually holding to account. So we're repurposing the session that we originally had planned for the board and the council to work together on some joint work that was originally in the corporate calendar, and instead we're drawing that into a workshop on holding to account, led by Acting Lead Governor Tremaine, and that will again kick off some ideas to look at kind of what are we doing, what can we do differently, how can we improve things, etc. as part of our overall recovery journey, again with a report for the COG's consideration in September. Then at the September COG we plan to do a workshop actually looking at values, behaviours, standards, training, what else do we need? So what do we really need to help us to put into action some of this new sort of renewed emphasis and focus on membership and representation and holding to account? Now, clearly we want to build on the work that the council's done already. You know, it's already had some thoughts on this. The pandemic has made us work differently, see things differently, and also I think there is a recognition that there are some things that the council isn't doing that actually there is, particularly with the new governors, a real desire to do, and I don't want to sort of steal any thunder from a conversation that will hopefully having in September about an excellent proposal that's come from one of our new governors, Helen Clark, about how we might actually want to start using some links and some networks that the governors have and actually use that for the benefit of the organisation. And this is really quite powerful stuff, and it's really going to kickstart some work that we do more more actively supporting the trust board in terms of its priorities and the people that it needs to reach out to in order to have a better understanding on priorities and focus and so on. So I'm really, really pleased to see this. We're going to start small, we're going to pilot it, we're going to use the workshops that we've got coming up, again, the membership and representation ones led by Chris Davison, to really help us understand actually what can the governors provide, and then certainly the governors will want to be coming to the board to say actually, so what support do you need? And again, in support of this very kind of really rich theme of kind of active work that the council is very keen to support, we've already got meetings lined up with Jean and with Kate and David, looking at our operational plans, looking at our strategy, looking at our quality count, so that we can get some early input from the executive team about actually, so how can we really engage the governors and their excellent networks into the communities for the trust's overall benefit.
Thank you, Fiona, and I thought it was just helpful to give everyone a bit of an update on kind of next steps from what we were doing at the initial conversation, and Fiona's helpfully highlighted a sort of set range of steps that are going to happen between now and our next Council of Governors meeting in September, and of course albeit the joint workshop that we were planning for August was originally the full board, clearly because it's going to be focused on sort of the holding the non-executive directors element to account. We're actually going to involve the non-execs in that workshop and stand execs down, which I think executive colleagues will already be aware of. So helpful to have that brief update. Thank you very much, Fiona. So on that basis, we'll note the update from the Council of Governors. And a final brief comment on the board development plan, Fiona. We've got that on the agenda. I think it's because we haven't formally developed a board development plan or programme for this year, so we just wanted to make a comment on that.
Yeah, and I think that's that given the circumstances in which we're operating, I think it is important that we retain a level of flexibility on actually what the board looks at in its sessions that it has actually identified. So there is carved out time in the board's calendar to undertake some development work, and certainly a key feature of that development work has been, or development stroke seminar approach has been, to ensure that we keep